All right, let's get started. Welcome to the UCSF Geriatrics Grand Rounds. I'm very pleased to introduce Dr. Jennifer Wolff. She is the Eugene and Mildred Lippitz Professor in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, meaning she came a long way. Dr. Wolff's research focuses on the care of persons with complex health needs and disabilities and applied studies and initiatives directed at better supporting them and their family caregivers within systems of care delivery. She has published extensively in this area and serves on many expert panels and consensus committees to share her expertise. And we are delighted to welcome her today, because we all care about our care partners.
Well, I'm really delighted to be here today and have the opportunity to get to meet many of you in person and by Zoom. I have thought so highly of the work coming out of the division for many years. So I framed my talk around impact. And I'll start off just with some brief level setting comments, then talk more specifically about the rapid potential for rapid cycle learning, and finish up and spend about half of the talk talking about the potential of consumer health information technology to engage and support care partners. So I'll start off talking about research impact in the context of dementia care and services. And research impact can be defined in many ways, but at its heart refers to the generation of benefits in one or more areas that extend beyond the academic knowledge base. And to the extent that health-oriented research is intended to benefit the well-being of patients, families, and society at large, it's critically important that we maximize value and minimize waste. I'm sure we would all agree. And so I don't think this is a provocative statement to say that the science of dementia care and caregiving has been relatively strong, and certainly stronger than the collective impact of our research to date. There are notable systems level gaps in dementia care. Half of people with dementia never receive a diagnosis. There are race and ethnicity inequities across the spectrum from prevalence to diagnosis, treatment, and care. Without diagnosis, it's impossible to identify those who are suffering from dementia or proactively address safety concerns and plan for the future. And we know that family caregivers and care partners are at the forefront of dementia care, but they are not routinely identified, and their needs for information, training, and support generally go unmet. And simultaneously, we know that primary care and healthcare is under tremendous stress with high rates of clinician and staff burnout. So the traditional approach to dissemination has been to communicate evidence to practitioners at the end of a scientific pipeline. And the idea of 17 years to turn a small proportion of original research into the benefit of patient care is a well-recognized problem. So a 2021 ARC systematic review commissioned by the NIA to compile the evidence on dementia care and services interventions identified more than 8,000 studies and included 850 studies in 350 pages of appendices and tables. Importantly, of the hundreds of randomized trials that had been undertaken in dementia care and services, the overwhelming majority were found to be disconnected from care systems of care delivery. And the admittedly stringent criteria found no studies met high or moderate evidence of benefit. So NIA and NIH have recognized the importance of trying to think about ways to do research differently. And they have invested heavily in pragmatic trials as a design that's equipped to overcome many of the evidence gaps and issues related to context and data constraints that were identified in the ARC review, as well as two subsequent NASM reports. So pragmatic trials are embedded in care delivery systems. They're connected to data and workflows. They focus on outcomes that matter with respect to meeting the criteria and the needs of individuals with decisional authority to implement a model. They provide information on how to reach target populations, to promote workforce integration, and they build on available reimbursement mechanisms. With that said, although pragmatic trials are equipped to overcome many issues related to traditional efficacy trials, there are important gaps. Key issues are that the data that are collected are often constrained to those that are collected in routine care, so they often are unable to provide information on a mechanism of action. There are important context-specific implementation challenges, so intervention that's implemented in one setting may not necessarily transfer directly to another. There's a narrow focus on outcomes that matter to stakeholders with the decisional authority to implement models, but not necessarily softer outcomes that may matter to patient and family or clinician or staff experiences. And it's important that individuals with complex care needs, like dementia, often require multiple levels of support. And so they may require more than one nudge or workflow change. And importantly, the way pragmatic trials have been funded have typically involved investigator-initiated projects that have a long gestation period of 5 to 7 years. So this is a graphical depiction of the NIA stage model, which was put forward initially in 2014 by Lisa Onken and has since served as the underpinning of the behavioral and social research portfolio of NIA. The model is nonlinear and recursive and is meant to compress the time between various phases of learning from basic research and intervention generation in stages 0 and 1, with stages 2 through 5 to test the efficacy, effectiveness, and implementation of a model. The model posits, importantly, that the work of a researcher is not complete until the intervention reaches its highest potency and is widely implemented in its intended population. A major focus of the stage model is understanding context, and not only does an intervention work, but does an intervention work as it's intended in the real world setting, in the varied setting and circumstances in which it's been deployed. And so a notable challenge in the current portfolio of NIA funding mechanisms is that projects to date have been typically disconnected. So whether learnings translate from one setting to another is somewhat arbitrary and involves a longer period for proposing and implementing studies sequentially one by one through individual investigator-initiated projects across different environments and organizations. And so this long gestation means that there are long gaps in understanding what works in what setting and in what circumstances. So I'm going to be a little more provocative in the next section in talking about the need for rapid cycle research and drawing on aspirational vision of the learning health system. So the learning health system has been talked about for more than a decade. It was defined by the Institute of Medicine, the precursor of the NASM, in 2013 as one in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process, patients and families as active partners in all elements, and new knowledge captured as an integral byproduct of the delivery experience. Importantly, motivation for the learning health system lies in inefficiencies, waste, and burden arising from complexity and fragmentation in systems of care, uncertainty about best practices, and a translation gap between scientific discovery and practice. And these are factors that are especially relevant in the context of dementia care. So the learning health system poses special opportunities for accelerating efforts to address real-world challenges in dementia care. And I won't read the slide, but the main point that I want to make is that our understanding of dementia prevalence, inequities, and care experiences overwhelmingly relies on curated data from national surveys or from analyses of de-identified administrative claims. and that these data provide important insight about care gaps and provide information about potential targets of intervention, but they're disconnected from systems that diagnose and care for individuals. And so therefore are poorly positioned to provide insight, real actionable insight on how to overcome these gaps. So I am unaware of existing learning health systems that specifically focus on dementia, but in a recent perspective, I and my co-authors identified building blocks with the motive and means for dementia learning health system applications. So in terms of motive, new reimbursement codes and care quality measure sets present opportunities for clinicians to diagnose dementia and deliver best practice principles and to be reimbursed. The fragmentation and high costs of dementia make it a model condition for organizations operating in value-based payment systems to benefit from improved care quality. The learning health system cares about people, and so there's motivation to address clinician and staff burnout. And in terms of means, the spread of electronic health records, population health workforce tools and technologies such as artificial intelligence facilitate new ways of overcoming systems level breakdowns. And so I just want to reprise the stage model and emphasize the reciprocal feedback loops that are here. And I think the learning health system provides new ways to think about rapid cycle learning and moving through these phases. For example, piloting small nudge interventions or changes in care that either fail fast forward or that can be scaled quickly. For example, moving directly from stage 1 to stage 4 to test a pilot study that worked well across a clinical service delivery line, and if that works, to potentially scale it more broadly across the system. So just to summarize, I'm arguing that learning health system principles merit attention as a complement to pragmatic trials by expanding the range of viable outcomes to critically important softer outcomes relating to care experiences, burdens, and efficiency, accelerating the pace of innovation and affording rapid cycle pilot testing to quickly discard infeasible options and refining and scaling those that work, and by affording opportunities of integrating data from the point of care in research, including from heterogeneous systems such as long-term services and supports, and information provided by care partners that are typically not included in population health initiatives, as well as by leveraging electronic health records to support intervention, delivery, or health system change, such as developing and testing innovations in a dementia care registry. And so finally, I'm going to spend most of my time finishing with some out-of-the-box thinking and what it might take to catalyze dementia care research and impact, drawing on learning health system principles and really focusing more on care partners and caregivers and the potential of consumer health information technologies. So it is well recognized that family caregivers and care partners are at the forefront of all aspects of dementia care. Supportive care partners in dementia care is a best practice principle in dementia care quality. It's one of 9 required elements in dementia care planning codes. It's a key element of the dementia management quality measurement set. It's embedded in the guide model reimbursement mechanism and payment level, and it's been linked to improved health and services use that economic modeling tells us would lead to notable systems levels cost savings if scaled widely. With that said, the invisibility of caregivers and care partners in care delivery presents a methodologic challenge because family caregivers and care partners operate outside formally recognized professional practice, financing, and regulatory arrangements. Their presence isn't systematically captured in a way that allows us to understand who has a family caregiver or care partner, who the caregiver is or care partner, what activities they perform, the capacity that they have to be able to undertake those activities, how their involvement affects care outcomes, and most notable to the main point of this talk is what benefits and value might be derived by translating evidence from research to policies and practices that bring about more explicit partnership and support for patients, care partners, as well as for the health system. And so I want to just read a quote from a 60-year-old woman who talked to our team about her interactions with the primary care clinicians who helped her husband, who had a mild cognitive impairment, and it provides some insight as to the caregiver role. And the quote says, if someone wants to be alone with him, if a doctor wants some alone time, that's fine. But the fact of the matter is he, her husband, is not going to remember what was talked about. And she goes on to say, clinicians get angry with me and they're like, let him speak, as if this is a picnic for me, which it is not. And as a matter of fact, it's very disturbing to know that he can't remember he had a stent put into his heart last month. And so the main point here is that the lack of a defined role for caregivers and care partners presents a number of challenges with respect to face-to-face and electronic interactions, and too often leaves them in an adversarial position and inhibits their ability to effectively advocate for the patient, to be able to access information that's appropriate and beneficial for them to be able to coordinate care or manage care at home and in the community. So the patient portal is, I'm sure as all of you know, is widely available as a form of consumer health information technology that allows patients to view sections of their electronic medical record and perform a variety of health management tasks. And the patient portal is widely available throughout care delivery as a way, a patient engagement tool. And so I've been thinking a lot about shared access as a functionality where patients can register a trusted family member or friend to access their health record in a registration process that affords the care partner their own unique identity credentials. And so this, I would say, as I've been thinking about this over more than a decade, is an important modality for thinking about care partner identification and support that's pragmatic and available. And there's a growing appreciation that of the importance of proper identity credentials for patient autonomy and control for both sharing and revoking access to their personal information, as well as legitimizing family involvement. It allows patients to identify who they want to involve in their care. And through bidirectional information exchanges, care partners can complete self-assessments that can be used in monitoring and tailoring outreach. And this could be potentially a game changer in thinking about interventions to support caregivers that allow for patient and care partner reported information. However, currently we know very little about how older adults, especially those with dementia, manage their care using the patient portal. So through an R35, our team has focused on really trying to better understand this landscape and how to think about embedded health information technology care partner interventions using the shared access to the portal. So we have undertaken a series of papers really to understand the landscape of shared portal access. In a first paper, which was led by Kelly Gleason, who's an assistant professor in the School of Nursing at Johns Hopkins, we reviewed the status quo, and we found 41 papers that reported on care partner use of the patient portal. Importantly, of all of the 7 studies that reported, that drew on EMR data, found fewer than 3% of adult patients had registered a care partner for their account. So uptake of shared access is incredibly low. However, 8 of the 13 studies that reported on survey data found more than 30% of care partners use the portal. So there's a disconnect between registration and actual use. And importantly, we found that shared access was far more common in populations who you would think need help with care navigation. And the qualitative studies, in qualitative studies, both patients and care partners overwhelmingly voiced benefits of shared access in terms of insight about patient health, activation, continuity of care, and convenience. In a second companion scoping review, we looked at patient portal-based interventions, and we found 81 studies that met inclusion criteria. And here we were really interested in understanding what was the it of the intervention. So we found that often they relied on patient-reported information, providing education, focusing on prevention. Importantly, we found no interventions that specifically targeted people with dementia, and very few included care partners. And then finally, I just want to highlight a paper that was led by Julia Bergdorf that appeared in JAGS that drew on the 2017 National Health and Aging Trend Study and National Study of Caregivers, which looked at how our older adults with disabilities and their care partners reporting that they use the portal. And so she found that basically 1 in 10 older adults with disabilities were the sole portal user. So the older adult used the portal and none of their caregivers did. 3% were joint users, and 14% solely relied on a family caregiver. And so she found that older adults were more likely to have a caregiver who used their portal on their behalf if they were older, had dementia, were homebound, or were Medicaid enrolled. And caregivers were more likely to use the older adults portal if they were experiencing strain, were college educated, and they were less likely to use the portal if they were Black versus white and part of a larger caregiving network. And some of this is really not all that surprising, but it's really sort of helpful in terms of reinforcing that portal-based interventions would identify that focused on identifying and engaging care partners would in fact reach a vulnerable target population and reach caregivers who are disproportionately experiencing strain in helping an older adult with dementia. So we actually know surprisingly little, as I mentioned, about actual patient portal use in dementia care. And so through the R35, we've been able to do a large data pull at Johns Hopkins, and where we've evaluated 5 years of patient portal activity on a cohort of about 50,000 older adults, about 3,100 who we flagged as having dementia based on diagnoses and problem lists, and about 46,000 who did not have dementia. And a key issue in the paper that was published last year in JAMA IM, led by Kelly Gleason, was that being registered for and having an active account as defined by logging in is virtually the same for older adults, regardless of dementia status. And although those with dementia diagnosis were 3 times more likely to have a registered care partner for their account, rates were really relatively low in both groups. So in the same paper, we examined portal use surrounding dementia diagnosis using 3 metrics of messaging in orange, sessions in gray, and a ratio of sessions to medical encounters in blue. And for all 3 measures, we find significantly more portal activity after receiving a dementia diagnosis as compared with the 12 months preceding diagnosis. And I think this is important in suggesting that the patient portal has value, that patients and care partners find that the portal has value in the context of a new dementia diagnosis. In a companion paper published in Alzheimer's and Dementia this year, we manually examined secure message threads sent from the accounts of older adults with dementia and found that 2/3 of messages were authored by a care partner, and that 95% of these messages involved the use of the patient's identity credentials. Most of the care partners were identified as spouses or adult children of the patient, but in 25% of the cases, the relationship was not clear. And this has important implications in thinking about the interpretation and actions of clinicians and staff following secure messaging in the care of an older adult. So systematic engagement of care partners in the context of the learning health system and patient portal holds promise for overcoming systems level challenges in dementia care. That's the premise of my talk. This is a schematic that my colleague Kate DeRoche put together that displays the continuum of innovation from existing portal-based functionalities through those that are more future focused that could be pursued to effectively engage and support care partners. So at a basic level, simply simplifying the registration processes and workflows for shared portal access, such as at the time of a dementia diagnosis, could help the care team know who the person living with dementia has chosen to involve in their care and capture the reality of shared care in that multiple care partners can be registered for the portal. So in partnership with Kate DeRoche, who's at Beth Israel Deaconess Medical Center and Harvard Medical School. She's also executive director of Open Notes. And with the support of the Johnny Hartford Foundation and Cambia Health Foundation, we're now wrapping up a multi-phase, multi-site project that's aimed at increasing adoption of shared portal access among care partners of older adults. We're working at 5 clinics from 3 geographically diverse organizations, all that had strong CMIO and clinician engagement. And in an 18-month planning phase, we developed the public awareness campaign, and we developed and implemented educational materials and workflows. And we're now wrapping up a 36-month demonstration where we're using mixed methods to evaluate the effects of this campaign. And I just want to show a few of our materials. We included exam room brochures and posters. We had talking points for clinicians and staff. We had slide decks that we used for presentations to raise awareness and get everyone on board and excited about this. We had smart phrases for clinicians, and all of the materials are in both English and Spanish. And we had like a tremendous amount of stakeholder engagement. We had like 73 engagements with patients, care partners, clinicians, staff, administrators, folks from the EMR teams. And we ended up with a tagline. We have 12 taglines, and we ended up with "Who knows you best?" And patients remember less than half of what their doctor says. Actually, people remember less than half of what their doctor says. As a way that that seemed to most resonate with the population. We had a number of other really interesting, who knows you best? And the concern was, well, you're suggesting that the clinicians don't know you well, and you plus, and the feedback was that seems like a dating site. So we're coming up with the taglines. So this is showing for 4 of the 5 clinics, month by month registration of having a registered care partner at 4 of the sites for the 24-month period, 12 months preceding the demonstration launch and 12 months post. And essentially what this shows is that there's very, very small but promising trends in terms of care partner registration. And I'll just say that these, the y-axes are on different scales. 3 of these are from a single system and focusing on primary care, where the care partner registration was much, much lower. The 2 clinics that focused on a geriatric population were much higher. So this one went from 10 to something like 18%. That was a geriatrics oriented clinic. And this is hot off the press. These are a graphical depiction of mixed effect models for estimated average patient portal logins by month for patients in the top panel and care partners in the bottom panel. This is the 12 months preceding and the 12 months following the demonstration implementation, with the intercept at 12 and a half months. And so I think that the key thing is that patient logins increased at a lesser magnitude following the intervention, and proxy logins somewhat increased following the intervention, suggesting that perhaps care partners were more aware of and likely to use their own identity credentials. And I just want to highlight again that these are different scales for the y-axis. So patients are ranging from like little more than 3.5 to 4.5 logins, and care partners are hovering, less than 0.8. So it's far lower. So once one or more care partners have been registered for the portal, a range of existing functionalities and novel functionalities could be used to embed, for example, standardized screening and assessment instruments as an efficient way to identify care partner perspectives on the needs of the person living with dementia, as well as to address unmet knowledge gaps. Electronically sharing information about dementia through print or video education tools, or providing tools and resources such as post-diagnosis anticipatory guidance could be helpful, as well as information about and referrals for legal and financial planning. And so 2 projects I'll just briefly mention. focus on care partner identification and support through our notes for care partners. So our notes is an electronic pre-visit agenda setting activity that was initially tested in a pilot project led by Open Notes at 4 sites. One was UC Health, University of Colorado, and UC Health has scaled this across the entire system. That's sort of an example of rapid fire learning health systems, sort of taking a small pilot and moving it forward at scale. So 2 days before a clinical visit, patients are asked to log into their portal account and complete 2 questions. And the 2 questions are, how have they been since their last visit? And what do they want to talk about at the upcoming visit? And this then gets filtered back into the health record. And so one of the colleagues that is part of our R35 is Hillary Lum at UC Health. And through the R35, we were able to adapt our notes in the geriatrics clinic to ask who's completing the R notes assessment and to be able to identify whether it's the patient or whether it's a care partner. And if so, who is that care partner? A second line of work has been supported by the Ralph C. Wilson Foundation. It's being led by Kate DeRoche. And it's an adaptation to identify patients who are completing our notes who have caregiving responsibilities. And this is being piloted in adult clinics, so not focused on the geriatric population. And she has added a question, a third question. So after answering the first 2 questions, caring for the health and wellness of someone else can be rewarding and really hard. This can, I can't read this. This can include helping with personal, it lists the range of activities. So it's basically helping identify patients before a visit who have caregiving responsibilities. And then patients who have caregiving responsibilities are given a link to the Archangel's Caregiver Intensity Index, which is a 2-minute survey that provides respondents with an overall score that ranges from 0 to 100 and a color, green, yellow, or red. So this index assesses where care partners need more support with their responsibilities and where things are going well. And they're provided links to curated resources in their local community. And so this project has been fielded it's been completed at 1 clinic and is still ongoing at 2 others. And very quickly, there's been about 20,000 patients who have responded to these questionnaires, and about 9,000 completed it at least once. The proportion of respondents who identified as caregivers ranged from 6 to 30%, based in part on how it was administered, whether it was administered systematically, where the response was lower, or whether it was something that individuals could opt into using a QR code, where the response was a lot lower in terms of being a caregiver, but the intensity was a lot higher. So this is like super interesting in terms of thinking about something that you could refine and scale more quickly. And then finally, at the top of this pyramid, technology such as artificial intelligence have a range of really exciting capabilities in terms of identifying and acting on patient and care partner reported information. And Kelly Gleason, who I previously mentioned, was recently awarded funding from the Johns Hopkins Artificial Technology Laboratory, and to build rule-based algorithms to identify care partners and non-medical concerns and needs that are raised during portal messages. So this could be basically a way to potentially, as shown here, ensure that care partner needs are recognized and that they receive resources and potentially reduce clinician and staff workloads. And so obviously there's a whole range of concerning questions. Nonetheless, AI is already embedded in Epic, and Kelly is planning to systematically and carefully build a natural language processing model that would be readily understood and to test it in a thoughtful way. And she has a paper that's forthcoming in JAGS, I think it could be out already, that provides proof of concept for this natural language processing model to identify non-patient portal messaging authors that really focuses on use of third-person pronouns and identifying the relationship of who's sending the message. And so I think the other thing is that through the John A. Hartford project, it's been clear that the use of just education and awareness is not sufficient to really change the game. And I think because of the growing reliance on patient-generated health data and using the portal to upload legal documents, it becomes increasingly more important to identify non-patient authors. And so the idea of using this kind of an approach to identify who is not a patient sending a message and then trying to get them registered for the portal is something that we've heard other systems are beginning to do. So it doesn't seem too out of the realm of possibility. And then I finally wanted to just finish with a conceptual framework that has really sort of come out of this R35 work to guide potential future systems level initiatives to support digital health equity. And essentially it's the combining the SIPES framework, which is a human factors framework for thinking about how work systems and work processes lead to outcomes, where we have integrated and specifically called out the role of the care partner, and thinking about the patient portal as a tool, including relational coordination theory as a framework for as a potential mechanism for facilitating care partner identification and engagement through HIT. And relational coordination has been widely described by Jody Gittel and colleagues at Brandeis. It proposes frequent, timely, accurate problem-solving communication reinforced by relationships that is built on shared goals, shared knowledge, and mutual respect, can best support task integration and performance. And it's been highly studied in a range of sectors, from the airline industry to the criminal justice system. And I would say that is, from the standpoint that it has found to be especially salient in task systems that involve high interdependence, uncertainty, and constrained time, seems particularly relevant in the context of dementia care. And then I'll just finish by making a plug for the Coalition for Care Partners that is basically a website, but meant to aggregate some of the information and resources from the projects that we've been developing. It includes all of the tools from the John A. Hartford project in terms of the shared access, trying to facilitate uptake of shared access. In addition to the website, we've launched a learning collaborative that meets quarterly and is a convening to bring together EMR vendors, care delivery organizations, patients, families, and clinicians who have an interest in care partner support through the portal. And it's a pretty active and engaged group. The last session that we had, we invited Greg Link, who's the lead at the Administration for Community Living on the RAISE national strategy to support family caregivers. And we'd love for our community to sort of feed back into that national strategy to support family caregivers. And so I'll just end there and open it up for questions. I didn't look.
Great. Any questions? I come up here to thank you for being one of our visiting professors.
Oh, thank you so much.
We have got you a plaque here. Hopefully this does not make your carry-on, it's
Oh, how beautiful.
but there we go. It says a teacher of excellence.
Oh, I love that. Thank you so much.
I'll give this to you. Open up for question. Maybe I'll just ask my first question. So I'm very interested to talk about learning health systems for dementia. And certainly we talk about that a lot, but some of the learning health systems seem like they're smaller programs, not actually the system. So I see people, caregivers have trouble, like, they're now in a skilled nursing facility, but that doesn't really connect or talk with the hospital. Yeah. Or, so I don't know, do you have any solutions for supporting people truly across systems? That's a tough part, but anyway. Yeah.
Well, so, no, it's a great question. I think that part of what my take is that there are no fully realized learning health systems. It's really an aspirational goal, and it's more like the principles of continuous learning and trying to, importantly, I think, in the context of dementia, is recognizing the complexity and the fragmentation, and really trying, I think, a key piece is integrating across the entire spectrum, where people are in nursing homes, they're in assisted living, they're in adult day, and how do we think about incorporating that information? And I think recognizing that it's all local, really care delivery systems are local. And so I think investing in the electronic platforms and in the workforce to try to, I guess, I think partly it's a registry. And so sort of thinking about how do we bake in those monitoring, like having a denominator, having a process for monitoring, and trying to collect that information where there are opportunities.
Alex.
It was terrific talk, Dan. Thank you so much. I want to ask a question about an analogy to pediatrics, which, are like appealing and also can be problematic on closer scrutiny.
Can you say that again?
Analogy to pediatrics. So I know a lot of people with young kids here, and you probably all are on your kids' patient portals, right? And yet, why are rates so low for caregivers of people with dementia?
Yeah.
And is that a generational thing? Is it that they don't know? I mean, what ought the rate be for caregivers of people living with dementia? Should it be 100% like it is for these parents of young children, or?
Yeah, so that's a great question. So I think that in the
Can you
first,
repeat the question?
so the question was in pediatrics, it's sort of it's like an expectation that the parent is registered for the care partner, and why is it not the case in dementia care? And I think, and should there be like what should the right rate be? And so I think the second question I don't have the answer to necessarily. I think it would probably be folks like you who are clinicians and geriatricians coming together to, although I would say that, probably from a best practice principles of dementia care, if part of the best practice principle is identifying and supporting care partners, it would potentially be everyone, but obviously there may be some heterogeneity in patient preferences that would need to be accommodated. In terms of the gaps in why are the rates so low? I think there are a lot of reasons for that. And there is a body of literature that has looked at this, and there's low awareness. It's cumbersome. So we have a secret shopper paper that's coming out that we're getting ready to publish from our Learning Collaborative, where we had our Learning Collaborative participants all tried to register for their portal, and then they reported back on their experiences. And as part of that group, there were like two emergency department clinicians. They couldn't figure it out after like 2 hours. So it's really hard. So, in some systems, they do it really well, and others not so well. Some systems don't even have shared access to the portal. The terminology is a problem. I keep using shared access, but like in Epic vendors, it's proxy access. And like, what is that? Like, it sort of proxy is a loaded term. And then I think also it's, not everyone wants to. I can't remember who I was talking with where they said their mom doesn't want to, was it Louis? It was, oh, I'm sorry. I can't remember. Anyway, where they, some patients don't want to, they're very happy to, and I would say probably more so for an older adult population than an adolescent population, that, they're just happy to have a family member, log in as themselves. But I think probably the other thing is that I am really excited about trying to partner with these EMR vendors would be, how do we better differentiate the credentials so that, care partners may have different benefits than patients, in terms of, more tailored resources that relate to that role. And again, this sort of relates to that idea of care partners not having a role. So could we use the portal as a way to have more clear roles, and all generating from the patient perspective, so patients can decide, not necessarily taking away their autonomy.
I was wondering if you run into any issues with like patients not wanting to give access to like their spouse or their daughter. If it's, I think it particularly like as more of our health history becomes online, like I might feel uncomfortable if you're letting my, daughter look at like everything that's happened to me in the medical world for the past 50 years. So I'm just wondering if there's any, work towards tailoring access to like the last 5 years or something, so that it's for, not including mental health conditions or something like that.
Yeah. Yeah, no, I think that's a really important issue. And actually, another reason why proper identity credentials are so important right now, they're just the access and the functionalities are mirror images. But I think if patients had the ability to determine what level of access various people in their network had, it would allow them, for example, to allow a direct care worker to schedule appointments or refill prescriptions, but not to view their health information if they don't want to, for just as one example. So I think that would be a sort of an example of how differentiating the benefits would potentially lead to more uptake.
Yeah, so thanks. That was just terrific and wonderful. I was like, have you found in any of your work, do caregivers ever use these records to talk about their own distress and needs? And are there any interventions, I mean, that like are seeking to use this as an opportunity? So like, you know, it just so happens you find out that it's the care partner and it's a pop-up that says, well, so how are you doing? And it's
Yeah. So we've done a lot of, through some of the formative work that I mentioned, there's been a lot of reviewing of the messaging, a lot. And really, it's very, very seldom, if ever, does a care partner say they need supports. They may mention, like in rare occasions, some level of burden, but it's very, very rare. And I think the idea of pop-ups is potentially where some of this could go in terms of, and I actually have heard of some systems, I think Vanderbilt has made this a priority. So if they see that a non-patient is authoring messages, they have some form of outreach to either close down an account or get the care partner registered. And so a pop-up, I think, would be a great way of, allowing the care partner to get registered, so that, to sort of clarify who it is who's interacting with the care delivery system. So Mike Steinman has a question. Can you talk about how you are thinking about building the ROI financial case for health systems to embrace shared EHR systems and implement them in a clinically sensible way? Well, so I love the question, which is exactly what the John A. Hartford Foundation keeps asking us at our at our monthly meetings. Yeah, so I think that we have not specifically included a costing element in our demonstration. We potentially could. I would say that the cost has been very low. It's been primarily, the cost of the materials, and then, I guess the time, spent in staff meetings, trying to facilitate uptake. So it's pretty low, but I would say that, it's also, as you could tell from our early findings, pretty modest in terms of benefits. So I think building a more compelling paradigm that involves, some form of an Epic or other EMR build, and, trying to, for example, change terminology and nomenclature potentially would be more costly, and potentially would benefit from the formal ROI.
I also have a question. In addition to, focusing on identifying the caregiver or the care partner, is there much on how to identify that the person has dementia? Because I'm struck by how poorly that is documented, or if you just use, large data sets, it comes back as very low percentages. And I know when we get e-consults, we're trying to figure out the clues, if it's a poor historian or something like that. Oh, maybe this person, so it's, how are you sort of identifying when patients have dementia? Because you're looking at care partners of patients with dementia. I'm just curious on how that part of dementia identification works.
Yeah. So I don't have a very satisfying answer, because the EMR poll that we've done at Hopkins has been sort of existing data, sort of mining ICDs and problem lists. And we've applied a method by Julie Bynum's group, led by Grodstein, to identify people with dementia. But I know that there has been a lot of work about, and I guess is E-Radar led by Lisa Barnes, is she here? So there have been algorithm development to better identify people with dementia than just pulling on ICDs. And so e-radar is one model. I would say that our group is also thinking more broadly about other patient-reported data that could be drawn on. And one that we are really interested in pursuing is it's especially salient at Hopkins, where we have very high uptake of the annual wellness visit, where one of the items, actually several of the items, relate to subjective memory concerns. And so we're thinking sort of about where we might go with piloting some of this work, and it potentially would be, you know, focusing on established patients who at an annual wellness visit indicate that they have subjective memory complaints, and you know, thinking about, you know, maybe we could, that would be a lever for both, I guess, developing some sort of a not a registry, but like identifying people who potentially could benefit from some outreach, and, you know, even simple interventions like if they don't have a documented advance directive, thinking about an advanced care planning conversation, or thinking about registering the care partner for the portal. So we're sort of in that space of like light lift interventions as opposed to multi-component complex interventions.
The Hartford Foundation, they really push the 4Ms or 5Ms
Oh, yeah.
model. Yeah,
Yes.
yeah. And I wonder if there's an equivalent for caregivers, you know, like financial well-being, mental well-being, social well-being.
That's really, I haven't thought about that before.
I just have a question about whose chart that would go in. Like, one thing that's really hard for me clinically is like, I'm assessing well-being for caregivers and then documenting in my patient's chart.
Yeah.
And there's almost like I need a file for the dyad of caregiver and patient, because it's this, I'm taking care of both people in a way, but I'm writing about someone, and then it's like, am I taking care of the kid? Like, I just get confused about.
Yeah, it's super, super complicated and confusing. I'm so glad you raised that. I think, and that has been like that has been the factor that has squashed a lot of like exciting ideas about how to think about really sort of developing meaningful interventions that would improve care quality, and through interacting to, you know, more multi-component interventions to support the caregiver. And so I know like David Rubin is the only person who I know who's been able to break that barrier down, because I think a lot of systems have a whole host of legal regulatory concerns. The one other place where I think there are opportunities is thinking about often the geriatrics clinic, where both patients are under the care of the same clinician. And that is also a really exciting potential opportunity for intervention for some of your wonderful geriatrics fellows who are looking for a project. Maybe that would be a place to start. Yeah, Krista.
It's been great. Thank you, Jennifer. How are you thinking about the opportunities coming up with the guide demonstration model? Is there anybody at Hopkins going in to be part of it? Are you thinking ahead to that?
Yeah, so Hopkins has put in an application. I've seen the application, but I'm not officially part of it. And I think that at this point, it's more, to me, seems like a promising opportunity for arguing that, listen, care partner, like you have to know something about the care partner to be able to move this model forward, and that affects payment. So I think there are, like, when that model rolls out, I have no doubt that many systems will begin to think about this. Although my understanding is it's being rolled out in some ways in a more, in sort of a more cautious manner. So it's probably going to be an area that would be ripe for thinking about more carefully in a more, you know, contained way.
All right, well, I think we are at time. Is there any other ones that popped up there?
There's one question from Leah Carliner. Patient portal use is important for outreach, but often leaves out more vulnerable groups. How are you thinking about making sure your approach doesn't widen disparities for care partners? And it's such an important question. Thank you for asking it. And I would agree that that it is really important that we focus on understanding and then trying to attenuate disparities. And I would say that in this context, you know, the EMR and HIT, it's out there. But if we are able to better leverage HIT in an efficient way, we can then identify who is not able to access IT and deploys scarce staff and clinician resources to addressing the needs of people who are more vulnerable and who are not able to benefit from the portal and other EMR-based resources.
All right, thank you so much.